Friends, in module 4, we'll be looking at what is called the critical appraisal of a study. Please understand that many of the aspects that we discuss here will overlap with the concepts of evidence-based surgery that we have talked about earlier. And we also have to check out the available tools for a critical appraisal. As you go along in this module, you'll realize that I have not got into the details of the available tools because that would be beyond the scope of this beginner course. But eventually we can have a look at the tools also. Basically in this module, the idea is to make you familiar with the questions that we have to ask before we make sure that we have critically appraised a given paper or a protocol. By definition, critical appraisal looks for validity of the data, completeness of reporting, the methods and procedures used, and conclusions as to whether they are in conformity with the data that has been generated in a study. The goal of a critical appraisal is to evaluate the strengths and weaknesses of a study, whether an appropriate study design was employed for a given research question, what were the metrics or the methodology by which the endpoints were measured, statistical methods employed, and as I said, the conclusions drawn. And finally, and by no means it is of any less importance than the other parts of an appraisal, finally we have to see if ethical standards were met in the study. This is a repeat of the slides we have shown you earlier. Types of studies may be descriptive or evaluative. Descriptive studies, cohort studies are the best. In evaluative studies, randomized controlled trials are the best. Primary literature consists of various kinds of studies, and I have listed a few as they are applicable to the kind of research question that we have. If you're looking at treatment efficiency of say 2 chemotherapeutic drugs, you need to have an RCT, a randomized controlled trial. If you're looking at diagnostic accuracy, a large prospective controlled cohort study would be the right one. Prognosis of a condition similarly would be on a large number of cohorts or a similar group of patients. Likewise, if you want to look at prevention measures or quality improvement, you have to compare them with 2 or 3 arms and do a randomized controlled trial. Secondary literature, of course, as I have said, would be an amalgamation of data that comes from primary literature. Meta-analysis and systematic reviews are the standards. But you can also look at critically appraised topics and consensus development reports and practice guidelines and the like. But as far as the basic data is concerned, the primary job of critical appraisal is to appraise an original study and usually applies to primary literature. Evaluation tools are available freely on the net. They will be different for different types of study. I'm not going into it in this module. It is not very important. But what is important is that in any type of study, you ask a certain fundamental set of questions. And in this module, we will make you familiar with what those questions are. The question is the study question relevant? That's very important. When you're looking at a study, either writing a protocol or evaluating a study that has already been done, whatever it is, you must ask a relevant, useful research question. As I keep giving the same example because it is most pronounced, if you have a new chemotherapeutic drug and you're doing an RCT comparing that with another drug, just looking at the size of a tumor at the end of 3 or 6 months of treatment is useless. The relevant study question should involve longevity or overall survival and quality of life. Does the study add anything new? Please understand that it is very difficult to keep on having path-breaking, you know, extremely important bits of scientific data to the literature. It's not at all easy. These science progresses with very small increments, and for our condition, the same research question, say which is asked in America or the UK, if it is asked and done on the Indian population, itself will be new, because most of the time we will not have any Indian data on a given research question. So please understand that it is not wrong to replicate a study done elsewhere on your population. What is the type of research question asked? You are looking at three aspects. What is the kind of cohort you have? What is the intervention that was done? And what was the outcome that was done? And in terms of epidemiological studies, you're looking at frequency of events and effectiveness of studies. So it is not only is it important to know whether a research question is relevant to your population or your practice, you must also know what is the type of the question that is asked. Was the study design appropriate for the question? Once you know what is the type and the expected outcome from a research question, you have to know if the study that was done was appropriate for that question. As we have said earlier, if you're looking at frequency of events, which is epidemiological, you would have an observational study or a prospective study or a cohort analysis. If you're looking at effectiveness and outcomes, then you're looking at randomized controlled trials or at least prospective interventional studies. Please note that when I say this at this juncture, for some of you where all these terms are new, it may look very, very confusing and beyond comprehension. But once you start doing this, once you start doing journal clubs and doing critical appraisal, everything will fall in place. So one needn't feel very desperate if you haven't understood what I've said so far. But you will find that very soon, perhaps after you have done critical appraisal of 4 or 5 papers, things will fall in place. Were sources of bias addressed? This is an important question because there are what are called confounding factors. For a given outcome, for example, wound infection rates, there can be several factors studied. Patient's diabetic status, nutritional status, amount of cautery used, presence of, say, infection in underlying tissues, so many factors. And so when you are looking at one intervention among all this, for example, using cautery versus a knife for a wound infection, you must know that other factors like nutrition, diabetes, and all other factors must be the same in the two groups. Otherwise, the results that you see from your intervention may well be due to other confounding factors. So if you have such factors, it is your job to make sure that you design your study in such a way that they won't adversely affect or skew your results. That is called systematic bias. A random error is something which is beyond a researcher's control. You have two groups which is done in good faith, and just by chance, the two groups may be slightly different. If that happens, it doesn't really skew the results in a main way, but it can affect the precision of the study. Between random error and systematic bias, random error is a relatively innocuous problem. Now, the flowchart for an RCT is an important thing. Consort is a consensus statement for RCTs or randomized trials. I won't go into the details of this, but it is now expected that if you do an RCT, you give a consort diagram which looks like this. What it basically tells you is the way you enrolled your subjects, the way you excluded a few people, the way you randomized, and the way you allocated. It also tells you how things happen in the follow-up period and in the analysis period stage of the study, and you are basically exposing or giving the data to show that you have not in any way compromised allocation or group analysis. Again, we'll go into the details as we go along a little later, But please understand that a consort flowchart looks like this, and that it is now almost mandatory for papers, for your papers to have the consort diagram in an RCT. Was the original protocol followed? This is very important. You'll find that as you go along in a study, you may not have enough numbers. You would have initially calculated a sample size, and if you can't get the numbers, then there's an issue. You may start analyzing well before those numbers were met. Was there any change in the inclusion or exclusion criteria? Was there any change in the intervention? Some machine goes bust and you start doing something else. Such things are just not allowed in a trial, because you need to have controlled situation for getting proper scientifically valid data. And so it's very important that when you look at the results section of a paper, you make sure that the protocol was followed diligently. Does the study test the stated hypothesis? It's another very fundamental and important question. Now, if you have data which perhaps does not support your hypothesis, the common tendency of researchers is to do what is called a post hoc analysis, which essentially means that you started off with some idea that you mentioned in your research question, and when you did not get the answer, then you start changing and doing what is called subgroup analysis. Try to get a statistically significant data. That is not allowed. So you must check whether such a thing was done or not. And also, you look at the consort chart and look at the data in the tables of the study. Make sure that they have not left out certain sections of the subjects. There must be no selective reporting. Every single patient that they started with must be accounted for at the end of the study as well. With the statistical analysis performed correctly, this is perhaps the most difficult. I think we as surgeons cannot really learn a lot of statistics. Certainly it's one of my weaker sections of my knowledge, but then you can always take the help of a professional statistician to look at the statistics part of your study. Do the data justify conclusions? This is something where we see a lot of discrepancy, particularly in the presentations when the postgraduates present their data. Conclusions can only be drawn on declared data. One of the commonest things is that you have a hypothesis with, say, 1 or 2 questions. Does the chemotherapy that we are giving, let us say, does it increase the overall survival? Now, you not only in your conclusions say yes or no depending on data, but you also start about saying how good the chemotherapeutic agent is, and that there are very few complications, and that the cost is not very high. Now, unless you have evaluated those things, unless your protocol looked at it as your goals or aims, your primary aim and secondary endpoint and primary endpoint that we spoke about. So unless you have mentioned it and actually collected data and displayed it in your results section, you cannot make statements. So statements without data backup are just not acceptable. Any conflict of interest? This is not very common in our scheme of things, particularly when postgraduates are involved. But if you have industry funding, or if even one of the investigators is paid as a consultancy, paid for consultancy as an investigator, things like that you have to declare, so that the reader is at liberty to decide whether it is indeed a conflict of interest or not. If you do not declare this information publicly, then it is a kind of misconduct. Now, critical appraisal, please note, is a difficult art and science to learn. It will come with practice, but there's no doubt that you need to keep doing it on a regular basis, and one of the best ways to do it is to do it in journal clubs, where you have several minds working on a given paper to throw up their ideas, and so your thinking also becomes sharper. And remember that it helps you to design your own protocols, because even before you start off on a study, you can critically appraise your protocol and see if it stands scrutiny. And if you have a good protocol and a good basic knowledge of critical appraisal, your papers will have a better chance of publication than otherwise. I close here and we go on to the next hands-on after a short presentation on how to do a journal club. Basically, journal club helps you to critically appraise a paper as a group. Thank you.